Hello, thanks for the opportunity to present here today. Today I'll be talking about how our standardized multimodal pain regimen impacted postoperative inpatient opioid utilization following bariatric surgery. These are our disclosures. So as many of you know, opioid use in surgical patients has received a lot of attention in recent years given the opioid epidemic. There have been a number of studies published recently that state, as we all know, postoperative prescribing practices are far outstriping actual patient utilization. A number of these studies, however, focus on what is happening after the patient leaves the hospital, and not necessarily what's going on while the patient is still with us. As such, we implemented a standardized multimodal pain management protocol and educational program following elective bariatric surgeries. The big component here is actually the educational program. This was based after previous work that we had done as a section, looking at patient pain satisfaction after they were discharged. And what we found was, of the patients who required more refills and were more dissatisfied with their pain management, a number of them were stating that they felt poorly informed about their non-opioid options. We hypothesized that this protocol would reduce inpatient opioid utilization after bariatric surgery. So this was a retrospective case control study. The inclusion criteria were patients undergoing bariatric surgery between April and March 2019. That would be the pre-intervention, pre-protocol group. And then the post-intervention or post-protocol group were patients undergoing bariatric surgery between October 2019 and December 2020. So this table details our protocol. You can see on that left-hand side the pre-intervention group. Preoperatively, they all received Tylenol, gabapentin, and a tap block with Exparel. Intraoperatively and postoperatively, management was really left up to the anesthesia and inpatient teams. And at discharge, everybody got 200 mils of oxycodone. In the post-intervention group, or protocol, consisted of the same preoperative meds, but also standardized teaching at a group pre-op class about pain management. And this teaching included things like non-opioid adjuncts, what we would do in the hospital to manage their pain, strategies they could use at home to manage their pain, safe disposal of opioids, and also risks and benefits of using opioids postoperatively. In the intraoperative setting, we routinely avoided use of intraoperative opioids. Ketamine or magnesium drips could be utilized at anesthesia's discretion. On the floor, we routinely used at least 2 scheduled non-opioid analgesics, and that included Tylenol and at least one of the following: Robaxin, Celebrex, Toradol, gabapentin, Lyrica, or carisoprodol. And then for breakthrough pain, we used Dilaudid followed by oxycodone if they were able to take pills. And then at discharge, we encouraged routine use of at least 1 non-opioid analgesic, and then we actually gave them the option to be discharged without any opioids at all. So they could go home with 0 if that's what they wished, and if they did need opioids, we gave them oxycodone 5 milligrams, 10 tablets. And these are our results. So a total of 359 patients were included in this analysis, 192 in the pre-group and 167 in the post-group. They were pretty similar in demographic character in terms of age, sex distribution, BMI. The most common procedure was a laparoscopic sleeve gastrectomy that comprised slightly less than half of the population, followed by laparoscopic bypass, that was about 1/3 of the population, followed by robot sleeve. And if you look at the 2 lines at the very bottom of the table, you can see when you look at hospital readmissions within 30 days, they were similar for both groups, but ED visits within 30 days were statistically significantly higher in the post group. When you look at the data more granularly, 4 of the 16 visits and 9 of the 30 visits were for abdominal pain as the chief complaint. And in the post group, of the 9, 1 had an intra-abdominal abscess, 1 had concern for ischemic bowel, 1 had an ileus, 1 had bleeding, which I bring up to say that perhaps not all of those visits were related to poor pain control and actually had underlying other pathology. This is a box and whisker plot that demonstrates inpatient opioid use in morphine milligram equivalents. The box corresponds to the 25th and 75th percentiles. The line is median and the X is mean. As you can see, there's a statistically significant difference in the pre and post groups. So in the pre-intervention group, the median MME use as an inpatient was about 135 MMEs. In the post-intervention group, it was 61.5 MMEs. What does that mean? In practical terms, 135 MMEs is about the equivalent of 18 5 milligram oxycodone pills. 61.5 is about the equivalent of 8 5 milligram oxycodone pills. This is inpatient opioid use by procedure. As you can see, for each procedure depicted here, there were statistically significant reductions. And finally, of the study population, 6 patients, 3 in the pre and 3 in the post-intervention group, actually used 0 opioids for their entire stay. MME prescribed at discharge also significantly decreased from that 300 we gave everybody to 75. And of the post-intervention patients, 15.6% actually went home with no opioids at discharge compared to 0 in the pre-intervention patients. So there are some weaknesses to this study. The first is that data regarding obesity-associated medical problems were not included in this study, and chronic pain disorders were not included in the analysis. And I bring this up because there's some data to suggest that there are other related medical problems, such as previous psychiatric hospitalizations or mood disorders or SES that may be associated with increased opioid utilization. But in conclusion, implementation of a standardized multimodal pain regimen and educational program we found significantly reduces postoperative inpatient opioid utilization in patients undergoing bariatric surgery. But future work is needed to move towards 0 opioid postoperative pain management and to optimize discharge opioid prescribing in this population. And that's all I have. Thank you.